Hi, I'm Harlan Krumholz, incoming editor of JACC, and I'm here with Marianna Fontana, who's published a remarkable article that we're happy to have in JACC and that she's presenting at the ESC Heart Failure meetings in Lisbon. Marianna, it's so nice to see you.
Thank you very much for the invitation. It's a pleasure for me to be here.
Yeah, so let's just talk about this paper. I think it's a brilliant idea. It's basically trying to help people understand what they might be able to use for prognosis in patients with amyloid. And you've taken a pretty simple idea and done a really great study. Could you just tell us a little bit about it?
Yes, of course. So the idea was really to use to test a very commonly used functional test, which is the 6-minute walking test, and assess the prognostic significance of not only the baseline value of the 6-minute walking test. So we take a cohort of patients, we assess the 6-minute walking test at baseline, and we assess the prognostic significance, but also test what is the minimal clinically meaningful change at 1 year. Because in amyloid, as in many other pathologies, we've got this problem that not only assessing prognosis at baseline, but actually tracking changes over time. How do we know that 1 year after the patient is better or worse? And I was really surprised when I look at the 6-minute walking test, because it's a test that we all use in clinical practice. And in amyloid is also extensively used in clinical trials. And I was very surprised to see that there was no study actually assessing neither the prognostic significance at baseline or defining what was a clinically meaningful change over a year. So what we did, we took more than 2,000 consecutive patients with ATTR cardiomyopathy who had the test at baseline. And then more than 1,100 patients had also the 6-minute walking test at 1 year. And so first, what we were able to show is that there was a strong prognostic significance of the 6-minute walking test baseline, both when we were considering different quartiles, and also we defined 350 meters as a clinically meaningful cutoff, a baseline. And then also what we found is that a change of 35 meters over a year, or a change of 5% in the 6-minute walking test, was what we defined a minimal clinically meaningful change. And that I think is very important as a clinicians, because in ATTR cardiomyopathy, we really struggle to define disease progression. And we recently published in JACC two simple ways to track disease progression, which is change in NT-proBNP and outpatient diuretic intensifications. And so the 6-minute walking test is a very nice addition to these very two simple parameters. And what we're seeing is that the change in 1, 2, 3, or none of these 3 markers nicely stratify the rate of disease progression at 1 year in these patients. So the idea was really to take a very simple test and understand what's really the significance in this patient population.
I love the idea of the simplicity. Here you've got a situation where, you're not talking about an expensive test, you're talking about a test anyone can do anywhere. I did want to ask you how you did it, though, because some people are not doing this in clinical practice. I mean, you have a specialized center, your protocols, everything's set up for these patients. If a patient comes in and someone wants to set up a 6-minute walk test, I mean, how is it? Is it how far are they walking, or when do they turn around? I mean, how are you doing it exactly?
So we follow the standard protocol, the standard advice on how to do the 6-minute walking test. So for example, each lap should be at least 30 meters in the corridor that you're using. The patient shouldn't have any distractions. There are specific instructions that the healthcare assistant provide to the patients. And then, of course, is also the collection of how the patients feel at the end of the test. So we use a very standardized protocol, which which very easy to follow and easy to find. Yes, whilst at the beginning, probably healthcare assistant needs a little bit of training to start doing the test. Actually, it's extremely simple. And that's exactly what I like about the 6-minute walking test. It's not about performing a very complicated cardiac MRI scans with difficult sequences or a very difficult echo protocol. It's an extremely simple test where the only thing you need you need to know the length of your corridor, which has to be at least 30 meters. And then the patient has to follow very, very simple instruction on doing the best that he can in that time frame.
So as you thought about this, I mean, this was looking at change over time, which I thought was great because a lot of people are just talking about it as a single measurement, and you're really looking at it for trajectory. But, so you've got a year separating, but what about 6 months? And what about 3 months? And you must be collecting it on every visit. So are you looking at it? Will you be looking at it in the future in different ways to try to understand, what it means in different time intervals?
Oh, definitely. I mean, this one is really, really scratching the surface. So I was just surprised that there was absolutely nothing about the 6-minute walking test in these diseases. So what we did, we just assessed the baseline and 1 year time point because we thought that that is the most commonly interval at which clinicians would perform the test. But definitely follow-up studies, even assessing a 6 or 3 months would be extremely useful. And also the reasons why we did that 1 year is because the first ATTR cardiomyopathy clinical trial in ATTR amyloidosis actually used the 6-minute walking test as an endpoint, so they changed at 1 year.
So I was going to ask you that because most of these patients weren't treated largely, right? Because you were looking at sort of your retrospective data. In your thinking now, I mean, they're using it in trials, but we'll be able to use it for response to therapy, heterogeneity in response to therapy, right? Because this simple test should be able to reflect progress.
Absolutely. Absolutely. In a way, when the Apollo B trial was designed and published, and as clinicians, we were really trying to interpret the results of the trial, like, was the change that was seen at 12 months clinically meaningful? I was really surprised by the fact that there was absolutely nothing. And this is actually where the idea of this study came from. We really need to put in a clinical context the results of a clinical trial. And so I said, okay, we've got huge amount of data and we just need to see what is a clinically meaningful change. But absolutely. So the cohort we had was a mix of treated and untreated because a large amount of these patients were in clinical trials, so with different type of compounds, and a proportion of these patients were also on tafamidis because once in the UK tafamidis is not available, we have an early access to medicine scheme. Some of these patients were on vutrisiran because they had opatisiran because they had a mixed phenotype. So we have this drug which are available for patients with mixed phenotypes, so not only cardiomyopathy but polyneuropathy. So within the cohort, we were able to do a lot of sensitivity analysis to make sure that the cutoff was working also in the different subsets, so clinical trials or disease-modifying treatment or patients untreated. So whilst, of course, more data on kind of weight silencer and stabilizer will be very useful to confirm this finding, I think that this study in a huge cohort of patients on disease-modifying treatment or not, clinical trials or not, give very, very robust data to really start thinking about the 6-minute walking test, both in the context of clinical trials and in clinical practice.
Yeah, well, congratulations. I mean, I really do think this is something everyone can put into practice. They can use this to benchmark information. They can look at it to help assess progress or decline. And like you said, you've made it so easy. Anyone around the world can implement this. This isn't going to be a resource constraint. And congratulations to you, everyone in your lab. And we're proud to publish this in JACC, and so happy that you could present this at the meetings in Lisbon.
Thank you very much for the opportunity to talk about this study. Thank you.
It's great to talk to you.